Without further ado, I want to welcome our final presenter today. Fernando Peña is joining us to talk about best practices in treating youth for SUD and mental health in parallel. So please help welcome Fernando.
Thank you. How cool is this? I'm so excited to be here with you guys. Working with kids, teenagers, you guys are my people. Obviously, if you are here, that means that this topic matters to you. And it's such a key, important topic. Something that's near and dear to my heart. I'm gonna be honest with you, I had no intention when I started my career years ago working with kids. So before I kind of launch into things, I just want to take a quick census of the room. I'm also an MI practitioner, so I'm a big fan of a menu of options, change options. And I have a lot of slides. I don't know about you guys, I over prepare, but I'm not a slides guy at all. Like, I think slides are kind of annoying. But I do know that there's visual learners that appreciate those. So the question for the room is, power through slides or make this a more meaningful sort of like interaction and discussion. So who wants the first one? Raise your hand. Who wants the second one? Raise your hand. All right, good. And the reason I mentioned that is, like I said, like, we've got an hour together. My joke is I have trouble saying my name in 15 minutes. So an hour is not going to be a lot of time. And this is obviously counseling, engaging people. This is a craft that needs to be practiced and learned and honed. And so my hope is at the end of this that we've sparked an interest to kind of continue forward and pushing forward and learning a little bit more before we get going. Some quick group agreements. It's weird that I come to these and I don't see people that I already know. If you've never seen me speak, I do sometimes have a tendency to say some what can seem controversial. To me, they're not controversial. The reason that I say that is that I talk I talk a lot about systemic inequity. And this is especially key in working with people with substance use disorders. The school to prison pipeline in this country is absolutely real. And we treat Black, brown, and indigenous boys at the school system level in a way that we wouldn't treat other students. And so, also, like I said, I'm kind of sick, so if my mouth and my brain don't link up properly, please just assume best intentions first. One of my favorite quotes is Hanlon's razor, never attribute to malice that which is adequately explained by ignorance. Together, everyone in here, I'm assuming, is here because they care. They want to help. They believe in the importance of intersectional identity. They believe in supporting people and caring for people and empathy and compassion based on the fact that they're human beings, and then honoring their particular identities. And so if something comes out different, weird, wrong, please just assume that it was just a mistake or ignorance. It's not actually meant to misgender or misidentify or anything like that. This will come key when I tell you a little bit more about me personally. In this room, there is a ton of collective wisdom. I was just asking Cassie what the crowd is, and she's like, we got everybody in here. We got mental health providers, we got SUD providers, we got doctors, peers. I love it. Together, we all cover different parts of the system that's underinvested and has lots of gaps in it, but between all of us, we have unique experiences that will lead to our collective wisdom, which will help us with better practices working with kids. And we also face unique challenges. And so that's the other thing, is that sometimes I have to be careful because I think I know too much sometimes, and then I forget that, oh yeah, a doctor is gonna have a different interaction with a patient or a client than I would, and I can't expect from them the same thing, but what they can contribute is valuable. One of my other key beliefs in life is that learning comes with struggle. It's okay to try and it's okay to fail. It's not okay to not try. You've only got to learn how to do things that you're not good at. So we have to struggle to learn, and so it's okay. No dumb or wrong questions. If you have a comment, if you feel really strongly about something, please bring it up and we'll chop it up and talk it through. Because through the struggle we'll learn, and we'll learn together. And then, I said this already, counseling is a craft. It's an art, a trade or occupation requiring special skill, especially manual skill. So The reason I bring that up is because especially with newer people in the field, and one of the coolest things in my career is I've gotten to work with lots of interns over the years, is new people always kind of come in and go, well, tell me what to do. It's not an if A, then B situation. So everyone's got to kind of get used to the it depends, right? Well, it depends. Well, it depends. So a lot of what I'm going to say here is obviously broad and generalized, and it's genuinely helpful, but I want to remind everyone that you're learning a craft, and it's through the doing of the craft daily that you actually get better, and that your best teachers are actually the clients and the teens that you're going to be working with. So any questions, comments about any of that? All right, great. Okay, a little bit about me. My accent might come out a little bit. I was born in New York City, in the Bronx, in 1976. Who said that? What'd you say? Yeah. I was born uptown in the boogie down Bronx, as we like to call it, in 1976, which, in case you guys don't know, is the best year ever in New York City. It was the birth of hip hop. Disco was popping off, punk rock music was popping off. City was also broke and underinvested, and the year before, the president had told the city to go suck eggs when they asked for a bailout. And so they weren't collecting the garbage, and we had the blackouts, and we had all that good stuff. So I grew up in the South Bronx. I grew up in the ghetto. Our schools did not have counselors. I read the statistic. I don't know if it's true, but I like to believe that it's true, that I grew up in the neighborhood that had the fewest trees per capita of anywhere in the United States. And as a kid in like 1983, 1984, when the crack epidemic hit in my neighborhood, I don't know if you guys know much about how crack dealing works, but they sell in vials, and the vials have caps on them, and they have different colors. And different dealers use different colors to mark their product, and so I would collect caps. My dad was like, what are you doing? And I'm like, oh, these are cool. There's like these little plastic caps, and I used to like to melt them and do stuff with them, but yeah. So I got to be standing here today. It's a long story, but really the salient part for this conversation is I'm a person in long-term recovery from a substance use disorder, and also a mental health disorder, and also food addiction. Actually, food addiction was my first addiction. Grew up in a lot of trauma and a lot of violence and destruction and pain, and I figured out when I was about 6 or 7 years old that if I ate an entire box of Frosted Flakes after school, I would get a little bit high, and it felt good, and I didn't feel anything for a while. And then later on in life, after I moved out of the hood and went to college for the first time, first person in my family to go to college, that was culture shock. I didn't realize how messed up I was until I got around people who weren't as messed up. And that's when, after years of being straight edge and a good, church-going kid, I started to develop a problem with alcohol, and then later on opiates and heroin, because that was cool in the 90s. The food was always there, PTSD, depression. When I was getting clean, about 8 years later, I always like to say I dropped out of college in my senior year. I was working on a philosophy degree, and I dropped out to pursue a career in drug addict. Doesn't pay very well. Actually costs a lot more than you make. But when I was getting clean, I was trying to figure out, what am I going to do next with my life? And what I looked back is at all the jobs that I'd had, what I really liked was connecting with people, talking with people. And I was like, okay, maybe that's a quick way now that I'm in my 30s and have to find a career somehow. To do that, I had some friends who moved to Portland after college. I was in Boston. If you're in the Northeast, you'll know that pretty much everyone goes to college in Boston. And so I moved here. I came to visit them, and after about a week, I fell in love with the place. And I was like, I'm moving there. Because I had moved back to New York City after Boston and was literally living in the same building where I used to buy weight in heroin. And so moved here, went to PCC, started working on my CADC. And when I was needing an internship, there were 2 internships that I was looking at. One was at Central City Concern, El Esperanza Juvenil, and the other one was at LifeWorks Northwest out in Washington County. LifeWorks Northwest was a paid internship, so I was like, I'm going to that one. My first day of internship, my supervisor walks up to me and he goes, "You want to do an assessment?" I was like, "What? I literally have no idea what you're talking about right now." And he's like, "Well, this guy only speaks Spanish and you are our only Spanish speaker here. So go do your best." I had no idea what I was doing. But that was the moment that I became sort of radicalized towards the needs of the BIPOC communities. I hate that term, by the way, but it's quicker than saying all the names. So that's when I became really radicalized to the idea, because I grew up in New York City where everyone's Latino, everyone's Black, everyone's from the West Indies. It's multicultural. It's not a big deal. Here, it's a big deal. And in Washington County, it was especially a big deal. And then all of a sudden, they were like, "Hey, you speak Spanish? We got the Sun Schools grant. Want to work with teens?" I was like, "What? Teens? I don't want to do that." And they're like, "Well, we need you to do it. Just give it a shot." And then all of a sudden, I was in love. I found my people. In every interaction I had with these kids, I saw all the pain and the heartache and the loss that was unacknowledged in me when I was 14, 15, 16 years old. And that's when I was like, whoa, this is amazing. Turns out I was pretty good at it. I think I'm also trained in motivation interviewing, and so I heard you guys had a session on MI already. MI is especially key with working with pretty much anyone, but with adolescents, it's the 100%. Like, if you're doing anything else, you're not doing anything else. Really. I mean, that's always the where to start. And so what I put up here says Red Zone Kids in the Hub. You'll hear me reference back to the Red Zone Kids a few times during this talk. Has anyone here ever worked with the Tiger Tualatin School District? Do you ever hear about the Red Zone Kids? No, I'm glad they probably got rid of the name. The Red Zone Kids were the kids who were on the cusp of full expulsion and not finishing school. These were the bad kids. These were the troublemakers, the hard kids, the ones who the school was really concerned about. And they had an assistant principal in charge of discipline there who created something called the Red Zone Kids. And it was like, we need to address these behavioral problems in our school, and we need to get them out of here. It will not come as a shock to you that the vast majority of the Red Zone Kids were Black and brown boys. To the point that one of the vice principal, or actually the assistant superintendent in charge of the alternative school programs actually was ready to file a civil rights violation against the school for how many of these kids were getting expelled from school for stuff that, frankly, white girls were not getting expelled for. So if you're a Black and brown boy and you're a problem at school, they go, "You're a problem." This was my older brother and my older sister back when I was growing up. But if you're a white girl, like, "What's wrong? You have so much potential. What is going on? How can we support you?" So I'm a substance use counselor, and I'm getting all these Red Zone kids. They're all popping up on my caseload, and these are the treatment resistant. These are the kids who don't want to do anything, and they don't care about their future, and they don't care about their lives. And lo and behold, they were coming to my groups, and they were coming to my sessions. And the school was like, "What did you do to get them to show up?" And I was like, "I didn't really do anything." And they're like, "No, you're doing something." And I was like, "No, literally, like, I'm not really doing anything." And I'll get to that a little bit later. But next to the Red Zone is the Hub. I got to be part of this really cool pilot project because the man's name was Andy McFarland. He was that assistant superintendent that I was just mentioning. Andy was like, "We got to do something about this. This is literally becoming a civil rights violation where 85% of the expulsions from school are Black and brown boys. And that's just not right." So we did a pilot program at the Durham Center Academy. I don't know if anyone knows the Durham Center. It's the alternative school. It's where the bad kids go. It's the behavioral issues. It's the pregnant girls. This is where they segregate them off from the main campus, and they send them to this school. And what we did at the Hub was we took the kids who were like they were expelled. Basically, they were expelled. They were never going to finish high school, and we selected about 27 of them. We were like, hey, here's this cool idea. And this is one of the things to put onto your list of things that work for working with adolescents. Here's a cool idea. How about you come to school at the Durham Center? We're going to, and you can come at 2:30 in the afternoon. You can come after school lets out. And then you'll come there, and part of being in this program, you'll have to have a drug and alcohol assessment with me. You'll have to have a mental health assessment with a colleague of mine that we selected, Erin, who was awesome at connecting with adolescents, and she and I would work together in tandem on our team, on the multidisciplinary team I was on at LifeWorks for the child and family team. And we were really good at working together with these hard kids who were hysterical and awesome and beautiful. And then you do 3 hours of school, Monday through Thursday, from 2:30 to 5:30. You'll have tutors for each subject on site, and you just work through, I think it was called Play-Doh or something was the system that they used, the computer system. And so we had the 27 kids that said yes. Again, no shock that the vast majority of the Red Zone kids, about 18 to 19 of them, were boys. Most of the boys were Black and Hispanic. In Tiger Tualatin, mostly Hispanic, not too many Black kids, and some white kids, and a few of the few girls. Most of the girls happen to have been Latina. Again, it's funny how that works out. And so we started doing assessments, and it was a 3-month pilot project. At the end of the 3-month pilot project, we had made, between Erin and I, we had made 11 DHS calls for child abuse. We had referred 8 kids to immediate interventions for suicidal ideation. The vast majority were diagnosed, dual diagnosed. They had co-occurring disorder for a substance use disorder, as well as mostly PTSD, depression, anxiety. Erin and I thought about really challenging all those externalizing diagnoses, oppositional defiant, conduct disorder, ADHD. Not saying those things aren't real, just saying that they're overdiagnosed, especially in the substance use population. So there's advice number 2, be careful about the label you're hanging on somebody. Because those will follow them around. Back in, whoever here is around my age will remember, like, this is gonna go on your permanent record as a thing in the movies. Well, your permanent record's your medical record. That is literally your permanent record. It follows you around, and anybody who's in here who's a medical provider, they'll tell you that they look at those and they see what you wrote on there because of the letters behind your name. They carry a lot of weight. And so they're going to believe you more than they're going to believe the person sitting in front of them. So you have to have humility around the diagnoses you're hanging on somebody. It's better to put a provisional. It's better to underdiagnose until you can get more information. So that was the hub. And then that was that pilot program, which turned into the hub, which was what's called a collective impact model school. We had so much success with that project. I think like 20 of the kids actually ended up finishing their credits. Of the 28. These were expelled kids. They actually finished. They also came to their appointments with Erin and I. Go figure. They really enjoyed coming after school. We gave them food, right? They loved it when I would pull them out of class. They really liked that one. And that's why that led to the hub, the Collective Impact Model School, which is, it doesn't exist anymore, but it was part of a program with Super Fresh Farms, also in Tiger Tualatin, and we had a building where the kids would come. They would come earlier this time. They would come at 10 a.m., and they would do a whole day at school, all there. And they would do work readiness on top of their education, mental health, drug and alcohol assessments. They could, at any point in time, request to speak to me or to Erin, the other therapist. And we did that for a year. And another rousing success. And then the reason I put That's What's Up is because that is the greatest compliment that anyone has ever given me professionally in my life. And that was given to me by a 17-year-old gang member in Washington County. I used to get a lot of kids referred from probation and parole who were gang members. And the courts could just not simply understand how it was that they were engaging in therapy. What did you do to them? Again, I did nothing. Well, no, you did something. I was like, okay, I'll tell you honestly. I never at any point in time told them to quit the gang, first thing. Never leave the gang. Gangs are important at that age. If for no other reason, they give you a sense of identity, a sense of security, a sense of belonging. And especially if you live in a really bad situation at home where you don't have any of those things. We all need those things, and especially the adolescent brain needs to separate out from their family and find who they are. And this is one of the places they find it. So there you go. You lose all credibility right away when you tell them to abandon their chosen family. They're also just never going to do it, and they're going to ignore you. I never told them to stop smoking weed. Never told them to stop drinking. Those were the things that the courts most wanted me to do. And I did none of those things, which is what I mean when I said I did nothing. They were like, well, what did you talk about? Check out that bias right there. What did you talk about? We talked about life. We talked about the future. We talked about trauma. We talked about mental health disorders. We talked about the past. So the person who said this to me, his street name was Grumpy. And if you can just imagine, a 17-year-old boy who's a gang member whose name Grumpy had to do something to earn that name, that moniker, a street name. And right before things got really bad for him, his twin sister, his fraternal twin sister died during childbirth. And his whole family went off the rails, including him. And nobody ever bothered to ask him about that. So I'd pull Grumpy out of class, we would talk, and then eventually he broke down crying and goes, you know, man, nobody's ever talked to me the way you talk to me. You're the only adult in my life that I can count on to actually care about what I think or how I feel. That resulted in the kids wanting to come see me, the adolescents wanting to come meet with me. And so this is where the That's What's Up comes in. They'd be like, man, my PO said I got to go do an assessment or whatever. I got LifeWorks. That's how I said. I got LifeWorks. And the kids be like, oh, for real? Who you got? I'm like, I don't know, some dude named Fernando. And they'd be like, that's what's up. That's why I put that on there. It was amazing. Okay, so now we start the big slides part of things. Raise your hand if you've heard of monitoring the future. Wow, we got what, 3, 4 maybe people. Okay, monitoring the future. So one of the biggest misconceptions about substance use disorders, as we already kind of touched on, is that just because someone uses, I don't know, did we? That might just be in my head. Who here believes that if someone's using drugs or alcohol, they actually just have a drug problem? Or that everyone that uses has a drug problem? Awesome. Oh, yes. You have no idea how many times people raise their hand to that. So this is especially a salient topic. Monitoring the Future is a study that's been going on since 1975 by SAMHSA, Substance Abuse Mental Health Services Administration. 1975, they began tracking drug use and attitudes towards school, parents, family, substances. They do it every 2 years. It's a huge study, like tens of thousands of people. It's longitudinal. They spread it out across the country. I actually have a friend, some of you might know Mitch Doig. He actually, when he was in school in Klamath, was one of the kids who filled out the Monitoring the Future. It's completely anonymous. And so the reason I put this on here is because it's a representative population. And what it's going to show, the next slide that I have here is going to show is that contrary to popular belief, most kids are not problem drug users. They just simply are not. However, more often than not, if they're going to get referred to treatment or to services in any way, shape, or form, it's going to be because of behaviors at school related to getting a substance use disorder, because of using cannabis or drinking, or they took ecstasy or something like that. But the key, and some more of the systemic inequity stuff, the data also shows that it's mostly boys that are getting referred for the substance use disorder stuff, and it's girls that are getting referred for mental health stuff, although the data shows that there is no demographic difference. There's no significant statistical difference in age of onset of use, which is usually about 10 or 11, or amongst the different genders that are being counted. No difference whatsoever at all. They both use at the same rates, they start at the same ages, but we refer boys through externalizing behavior, we refer girls through internalizing depression, anxiety, all that sort of stuff. So monitoring the future slides, this is just more to kind of back up. This is the total of any illicit drug use, and I hope you can see it, but what you'll notice is the peak was back here. This is in the 70s, and then we saw a precipitous drop through here. The different lines that you're looking at, the green is 8th grade, the blue is 10th grade, and then the top line is 12th graders. Now, I want you to understand that this slide includes any illicit drug, and by that they include alcohol and nicotine. So what we're looking at here is about 30-something%, right, in this line right here, at the height, but that's including alcohol and nicotine in that statistic. So 30% sounds like a lot, especially for 12th graders. For the 8th graders, we're closer around 10%. However, if you remove cannabis and alcohol, what do you see? Now we're down, way down. You know, we're way down here. This is like 4% right here, right? And so the other thing is, where was the peak? Yeah, that's dates on the bottom. All the way on the left is 1975, and it jumps every 5 years. So the next one, 1980, 85. So our peak was 75. People were partying hard. High schoolers were partying hard in the 70s. If you've seen Dazed and Confused, yeah. That's what was going on. But precipitous drops. We saw a spike in the 90s. This is my cohort right here, when we were using all the heroin and ecstasy. But everything has been down, down, down. And the most recent statistics right here, this spike right here, can anyone guess? This is 2020. What was this spike, this drop? COVID. Yeah. So COVID, we saw a very, very hard drop. And then it's picked up a little bit. But look how far down it is, even from the 90s, or much in the 70s. So what we're looking at with 8th graders especially is less than 4% of 8th graders are actually using substance use, having drug problems, or using drugs. Sorry, not saying drug problems. They're actually using drugs. I didn't put all the other slides. You can find these. They're all published for free online, Monitoring the Future. I greatly encourage you to read these. It will add a lot of context to your work. Everyone right now is very, 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 very concerned about fentanyl. I'm not going to say that fentanyl is not concerning. I'm also going to say that fentanyl is not very different in kind to previous drug panics we've seen. You already heard me mention the crack epidemic. I remember growing up and hearing about crack babies, and we've never seen anything like this before. So the truth of the matter is that we have. And there are protocols to work with that. But when it comes to teenagers, we're talking about less than 0.5% of teenagers are using opiates, according to Monitoring the Future. And actually, I think one of the most dangerous things, and here's another thing to remember about how to work with teens, is that experimentation with substances is normal. It is normal. Completely normal. Actually, the worst thing about fentanyl is that because it's contaminated the drug supply, is that it's made it so that kids can't experiment safely anymore. The vast majority of kids who are dying from fentanyl overdoses are doing so accidentally, thinking they're taking ecstasy or taking something else. And so, any questions, comments about that? Okay, I'm glad that landed okay, because some people, when I start talking about fentanyl, they get a little bit worried about it. It is a problem, and it is a severe problem. Good news, just this is not part of this talk, but good news is there's increasing data showing that the tried and true tested methadone is working really, really good. Really, really good to manage fentanyl use. And the thing that makes fentanyl most unique is how trafficable it is. It's so potent that you don't need to have, a suitcase can get the city high for like a week. So that's really the biggest thing about it. It's still just an opiate. Methadone works great. Okay, I just kind of talked about this, but this is for the numbers, people. The key takeaway here is prevalence levels in 22 were 9% for 8th graders, 10 for 10th graders, and 13 for 12th graders. However, in 2021, we were at near or peak levels, and that was 10, 18, and 21 respectively for 8th, 10th, and 12th. So the proportion of these age groups using illicit drugs other than marijuana has declined by more than half since then. They're using less. They are using less. So, question. Why do you think I started here talking about stage setting about how many kids are actually using drugs and alcohol in a conversation around dual diagnosis? Yeah, in the back.
Maybe because it's more important to start with mental health than with substance use?
Bam. All right. Yes. Absolutely. The whole point of this presentation is all teens are dual diagnosis. Absolutely. Because like I said, I'm sick and I was putting these slides together on the fly. I had some other stuff going on. But I read this really interesting study that I forgot to include in here. Basically, they did a longitudinal study of therapists. And therapists all agree that you need to treat dual diagnosis and you need to consider co-occurring disorders, but less than 10% know how to accurately screen for a substance use disorder. The funny part is that 90% of them also say that they're really good at treating substance use disorders. How does that work? They're not even screening it properly. And then, no offense to any medical practitioners, doctors in this room, studies are also showing that doctors are especially bad at diagnosing substance use disorders. There's a lot of unique challenges to that job that make it really hard to do that anyway, so I don't want to make it seem like it's all their fault. But we have this interesting, me and this gentleman right here, I forgot your name already. We were chatting before this. We have this interesting thing about, we call it a co-occurring disorder, as if substance use disorder is not in the DSM already. As if it's not a mental health disorder already. In fact, it's probably the most common mental health disorder that we have out there. And we don't reimburse at the same rates. This is a CareOregon talk. They could do something about that, right? We don't reimburse for substance use disorder at the same rates that we reimburse for mental health disorders. We somehow segment off that treatment from mental health treatment, when what we know is that substances work great if you have a co-occurring mental health disorder and don't have good coping skills. They work. Trust me, I know. They work really well to manage mental health symptoms. And so we have to be treating both, as this woman said in the back. We have to start from the assumption that both are present, not that both aren't present. So this is more just kind of making the case. Estimated rates of co-occurring mental illness among adolescents with substance use disorder range from 60 to 75%. So everyone here who is treating a teenager who has not asked that, treating them for a mental health disorder, whichever kind of disorder it is, if you have not asked them about their substance use, you're not doing your job. You are not doing your job. You don't have to refer them to someone else. You can ask. There's this weird thing about how education in this country works for mental health that I don't know if this is still true, but part of my team at LifeWorks, some of you may have gone through there. Sally Rasmussen was my supervisor. She also teaches at Lewis and Clark. She's a LPC and a CADC3. And she was like, yeah, you can graduate from Lewis and Clark with an LPC and not take a single class on substance use disorders. Not a single class. Still true.
For all programs, including the School of Social Work. Not a single sense class is required.
Check that out. 60 to 75%, and you can go through your entire hundreds of thousands of dollars educational career and not learn about one of the most common mental health disorders that exist. That's bonkers. It's absolutely bonkers. So another one of those little things you want to put an asterisk on. If you're not asking, you're not doing your job. Now, it's another weird thing about this disorder is that we tend to think that you have to have had it to know how to talk about it. Hogwash. That's nonsense. Some of the best counselors I've ever met in my life were the squarest, nerdiest, don't even drink people in the world. People you're like, oh, I don't even want to hang out with this guy. And they're amazing, amazing counselors, amazing substance use disorder counselors working with teens. Because when we get to the end where I get some more really specific things on top of the little ones I'm peppering in, they knew how to actually just engage with teens. Among adolescents with no prior substance use, the rates of first-time use for drugs or alcohol in the previous year are higher in those who have a major depressive episode. So there you go. If you're treating a kid for depression, who here was a teenager? Who here was depressed or messed up as a teenager? There you go. You guys were all predisposed to use drugs and alcohol. And so were all the kids you're treating. It's the same thing with anxiety. It's the same thing with PTSD. It's the same thing with, adjustment disorders and all that kind of good stuff. I highlighted a few things here because of the red zone kids who meant so much to me, but other commonly documented co-occurring mental health disorders are conduct disorders, oppositional defiant, ADHD. Those are all externalizing disorders. They also tend to be diagnosed more commonly with which demographic of people? There we go, boys. Not just black and brown boys, but all boys. So, interesting how the boys end up in treatment for substance use disorders for the way they present, the unique ways that boys present mental health challenges that they may be having. And they end up in your substance use disorder groups or treatment or whatever. This is more kind of just building the case for how all kids are having substance use disorders, but I put this in there because this approaches the statistics from the other side, which is up to 45% of adolescents and young adults with mental health disorders have a co-occurring substance use, and 65% is the other way around. Again, I wonder how much of that is actually up to the study, knowing that we know experimentation is normal and the unique challenges of being in school in this country. Adverse consequences. So this is SAMHSA's sort of definition, part of SAMHSA's definition of a substance use disorder, a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. So I highlighted the adverse consequences because adverse consequences and conduct disorder, oppositional defiant disorder, and ADHD all produce adverse consequences. So we have all these kids who are being referred to drug and alcohol treatment, getting arrested, getting expelled from school, who are having very, very deep emotional problems that are not being addressed because we're so worried about not being able to sit still in class. I absolutely went bonkers on a music teacher when I was in 10th grade. Like, didn't quite throw the chair, but I was going to. And what nobody saw when I got suspended was that my dad, I had to, a couple of nights before, I was at the state police barracks doing a restraining order against my dad, who was trying to kill the entire family. Nobody asked me about that. Again, this is more just, it says here, when a mental health disorder goes undiagnosed or untreated, an adolescent will often attempt to self-medicate or self-treat with drugs or alcohol. If you're not asking, you're not doing your job. The asking can be tough with adolescents because they view you as a part of the system, a part of their parents. And we'll get to that a little bit in a sec. I'm gonna push forward the red zone kids. You're seeing why I talked about them and how these are the kids that, as we started to address them holistically and all their issues, their dual diagnosis concerns, they started to actually thrive, they started to do better. A lot of them still had a lot of trouble. I've not kept up with any of them, but I would hope that the bulk of them are doing better. This is the slide, the statistic I was telling you about earlier. However, a few people reported using formal assessment practices or treatment protocols for co-occurring disorders. I love it. It's that I just find it interesting how we blame the clients for their problems and then don't acknowledge that our system does not train the practitioners to deal with helping them with those problems. Here we go. What works? So let's do a quick definition of recovery because I think it's really key and it helps also contextualize working with adolescents from a motivational interviewing perspective. Recovery signals a dramatic shift in the expectations for positive outcomes for individuals who experience mental and substance use conditions or co-occurring of the two. SAMHSA's working definition of recovery defines recovery as a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. Why did I make this so much bigger? Live self-directed lives when talking about working with adolescents.
It's hard for them. They don't have that luxury. They're under control.
Yeah. Why else? Absolutely. They're under control. They don't have completely self-directed lives. What else?
Nobody asks them what they want.
Nobody asks them what they want. What else? They also often are still trying to figure out what they want. They don't know. We don't appreciate the fact that a 9-year-old and a 15-year-old are very different. And they're still trying to figure out who they are when they're 15, and they still need mom and dad, and they still need input, and they still need adults. But what they don't need is adults in the same way they did when they were 8. They don't. We want to teach them to live self-directed lives. The definition, SAMHSA's definition of recovery is all about a process of achieving, of moving towards. And so one of the most common things that we hear, that we experience for anybody going into substance use disorder treatment, regardless of their age, is, well, you need to stop using. Why? And especially with kids who, as we just saw, don't often have a problem. They're experimenting. So it's all about self and strive to reach their full potential. I can guarantee you that I had some of the hardest actual kids who were accurately diagnosed with an opiate use disorder at 16 who still wanted to graduate high school. They still wanted to have a family and a career and a future. They knew what they were doing was killing them, but they still wanted those. And so we just worked on the next day. We worked on, what do you want to talk about today? Where do you want to get to today? The other thing that SAMHSA talks about is hope. In the working definition of recovery, they talk about hope. The belief that these challenges and conditions can be overcome is the foundation of recovery. How does it feel when somebody tells you you're not going to succeed if you continue blank behavior? In MI, we talk about resist the urge to rescue, right? You guys, a lot of people have heard that. Well, guess what? One of the biggest ways we try to rescue people with substance use disorders is we start to tell them that if they don't change that behavior, they're not going to have a better future and a better life. Is that giving anybody hope for anything? At my organization, the Northwest Instituto Latino, we do a lot of direct street outreach for harm reduction. And I love it when the homeless guys come in and they're still high and they just want some food or some water. Or they just want to figure out how to get their medications. That's hope. When we meet that need, instead of talking about getting off the street and getting off drugs or getting their mental health stuff, we give them hope, and they want to come back. They feel heard. A person's recovery is built on his or her strengths, talents, coping abilities, resources, and inherent values. I'll say that again. Strengths, talents, coping abilities, resources, and inherent values. If you are not sitting in front of these kids and acknowledging that they have strength, that they have natural resources to build on, that they have wisdom. Yes, 16-year-olds have a ton of wisdom. They have 16-year-old wisdom. It's awesome. We're going to talk about that in a second here if we can get to it. And then it's got to be holistic. This is back to the whole dual diagnosis approach. It's highly personal, many pathways, treatment, medication, faith-based approaches, peer support, family support, self-care, other approaches. We hear a lot of talk about adolescents and kids with prevention. There's different kinds of prevention. There's good prevention and there's not so good prevention. Good prevention is giving people something to do. Positive adults, things, job training, after school activities, all the stuff that our system is underfunded. And so telling kids that drugs are bad, while every single other message in our culture is telling them something different is not going to get you anywhere. That's not actual prevention. Continual growth. I'm going to push forward okay, this is something that I wanted us to do together. I want everyone to take a second and think back to when they were teenagers, as we all know, every single one in here was, because you guys just said so. Although I always wanted to be an old man for some reason. So I want you to think back to a time where you were really struggling when you were a teenager. Something was really weighing on you, something you'd be willing to share with the rest of the group. And now think of a person that was absolutely 100% not helpful at all. And then discuss a little bit and come up with some kind of common themes that emerge about what the unhelpful person did. So just take like 2 minutes to do that, because this is part of that collective wisdom. I'd love to hear back some of the common themes that emerged. What were the things that they did that were not helpful? Say more. Say more about that.
We talked about breaking boundaries in self-disclosure and breaking boundaries in physically hanging out with people outside of programs or needing help in one way and receiving help in another way from folks.
So the adult that was supposed to be helping was getting some of their own personal sort of needs met through that interaction or behavior. Yes, that happens. Absolutely. What else? There was a lot of talking. I know there's got to be other stuff happening over here.
We were just talking about dismissive comments by adults, like, you're going to be okay, it's okay, not being heard. You say something, and they're like, they're not using active listening, right? No reflective statements, just like, it's going to be okay. So very dismissive of what you're going through, or asking questions like, what's wrong with you? You know, those kind of things.
Yeah, the dismissive comment. You're going to be okay. This is my favorite one. You don't know what it's like. You're only 16. Right? Yeah, dismissive comments, right? How did that make you feel? Basically, invisible. Who else? What else?
We talked about not being able to find the right fit for a therapist, and just like how it's challenging when like the parents or the caregiver aren't resourced enough to like keep looking. And so the kid's just like, okay, I guess I'm in this room with a bunch of little kid toys, even though I'm a 16-year-old kid or something. So just feeling like this treatment is not for me. I'm just going to do it because I have to.
Yeah, so the parents, like I kind of touched on that a little bit too, right? Just not acknowledging that like there's a big difference between a therapist who's really good at like 8-year-olds. I am not. You give me anyone under 11 years old and I'm just like, I have no idea. But yeah, and then you also highlighted something else very important in there, which was the parents are sitting in the room too. So who's the client? Who is the client at that point? And often, as if through our own traumas, our own burnout, our own tiredness, our own levels of expertise as practitioners, we side with the client or with the parent instead of the teen. One of the biggest mistakes I made, I had this one kiddo who was 16 and he was on the autism spectrum. This kid was rad. He was amazing, and his mom walked in the door, and the first thing she did was started telling me his entire treatment and medical history, and this poor kid sitting there, and then I started to realize that I was responding to mom and talking about him as if he wasn't in the room, and referring to him in the third person in front of his face, and then I caught myself, and I excused mom, and I was like, hey man, I'm really sorry. What do you think about everything? I just screwed up. I messed up, man. I was acting like you're not even here, and you're sitting right here. And then this is one of those kids who kept engaging in treatment. I'll be honest, sometimes I had no idea what I was doing with him, but he knew. My supervisor used to tell me, he's like, you may not know, but he does. And he's coming and he's talking to you about stuff. He's doing better at school. That's a win. Working on that process of recovery, right? Building some hope. His mom told me that I used to, because he wore cool t-shirts, that after a while, he would make her buy him a new t-shirt before coming to see us so that I could be like, dude, is that a kitten driving a Camaro through space with a dragon? And he's like, he'd be like, yes. It's like, that shirt's pretty awesome. And then we would talk about his t-shirt collection. So I want to do real quick the same, actually we'll just do it as a group. Now think of somebody in that same situation who was helpful, an adult who was helpful. What did they do? And we'll just freestyle it because we're running short on time. So anybody, speak up. Somebody who was helpful, what did they do that was actually helpful?
Positive regard.
Yeah, curiosity, non-judgmental, unconditional positive regard is astounding. How well it works, especially with adolescents. The adolescent brain is, I see you back there. The adolescent brain is cued into authenticity, right? They understand BS in a way that we never will. They can feel it. They know if you're being genuine. They know if you actually care. Unconditional positive regard. Yeah, it sucks to have to come see us sometimes. Acknowledge that. Don't try to convince them that it doesn't suck. Say to them, where would you rather be? If you could be anywhere else right now other than right here doing this, where would you be? And what would you be doing? And be genuinely curious about the answer to that and have that conversation in the back there.
Relating to me. Like, I know that for me personally, when I went to my dad the first time and admitted to him that I had an issue with drugs, he looked at me and he's British. I got to do his accent. Oh, Charlotte, you know, I have never had that problem myself, but I think I understand, because if someone said to me, you can never have Ben and Jerry's again, I just don't know if I could do it. And so relating, not condemning.
Yeah, relating. And also, like, what I heard there was a genuine desire to listen, to understand, right? That's actually just radical empathy right there, right? Empathy versus sympathy, you know, the whole Brene Brown and all that kind of stuff, right? You know, I believe that. I just, you know, I assume most people know what I meant. But yeah, remember, empathy is like, I may not know what you're going through. However, I can imagine. Good news is we were all adolescents, as we found out. And so we can kind of relate anyway. So we have both the empathy and the sympathy sometimes. Who else? What else works? What else worked? Yeah, in the back there.
I was gonna say something about like actually asking the peer like what you can share like beforehand, or like at kind of checking in with them, if that makes sense. Like with my peers, or if I was in like a situation with them, I'd be like, hey, like, do you want to introduce me as your peer? Do you want to say I'm like your friend, or do you want me to like seeing what they're comfortable with? Because I know that some of my peers, no, they don't want their friends knowing that they're hanging out with like a peer support specialist, because then it's like, what is a peer support specialist? Like, why are you doing this? And like, so just really respecting those boundaries and understanding that not everyone wants to kind of be like front and forward with everything, and just kind of understanding that it is kind of a process, which I will say that wasn't what I was going to originally say, but yeah.
Yeah, you know, what I heard actually there was supporting their autonomy. What do you want? The thing that nobody ever asks most teenagers, especially once they're in trouble for something or they're being brought to a therapist's office, is, well, what do you want? What's actually the problem you want to talk about? You had no idea how many parents would come to me and their biggest concern was how much their kid's playing video games. He has no friends. He doesn't hang out with anybody. He's always alone. He's always playing video games. It's like, well, Mom and Dad, do you know what Xbox Live is? Do you know what Twitch is? He's not in there by himself. He's in there with like 35 people right now. And so asking, what do you want? What do you need? Engaging with them in a meaningful way. The wisdom of the teenage brain, they think more abstractly than smaller children. Very justice-minded. This is great. Why? Well, why is it that way? I don't know. What do you think? Tell me about it. How do you see it? And don't try to convince them that they're wrong. This is great. The abstract thinking, the concern with philosophy, politics, social issues. I'm still a radical right now from all the like Chuck D from Public Enemy and all the punk rock music I listened to made me who I am today. I discovered that when I was 12. I'm still completely a political radical because of that. Absolutely transformative. And that's great conversations to have to engage with kids. You start talking about those things, eventually you're going to come back. They're going to see you're being authentic, you genuinely care, and they're going to start talking to you about the other stuff that you're supposed to be talking about, that Mom and Dad want you to be talking about. Kids also like to set goals. However, they don't want to set a goal for 40 years from now. So smaller goals, right? Today, tomorrow, next week. Help them be realistic about setting the goal. That's a pretty big one. Can you actually do that by next week? No. Well, let's focus on what you can. But these are all the things that as the teenage brain starts to emerge that you have to be talking about when you're trying to engage them in treatment. So again, this is more stuff that we won't have to, I apologize, I don't have time to cover. And this is some practical stuff that I had been mentioning all along. Appointment timing. In some of the treatment programs that I've been fortunate enough to work with or to help set up through my work as a clinical supervisor, director, and now executive director, one of the first things I did was just like, that group is too early. That appointment is way too early. If you know anything about physiology of adolescence, you need a lot more sleep. Why do we make school start at 8:15 in the morning when we know for a fact that they're not actually awake till about 10:30? So I just made my appointments later. I put my assessment slots at 11:45. And all of a sudden, everyone was showing up to their assessment slots instead of having them show up at 8:30. And if they showed up, the ones that did show up at 8:30, they were still half asleep. And so it was like pulling teeth. So appointment timing, provide snacks. Food is an evidence-based practice. Food is an evidence-based. Anybody who is here as an administrator, a director, or a funder, provide money for food and for snacks to your clinicians to use for their clients and their groups. Fernando, how did you get all these bad kids to show up to your group after school every day? My office was directly next to Sunset High School. And my treatment groups were packed with all the bad kids. And you know why? Because they would show up at 3, and at 2:30 I'd go to Taco Bell, and out of my own pocket I would buy 2 boxes of 10 packs of tacos. I'd buy 20 tacos or a pizza, and every single one of those kids would show up and be like, Fernando has snacks. Candy bars, big ones. We would gamify things, but provide snacks, have food available. In-depth informed consent is essential, and go slow. If your informed consent is even with an adult, if your informed consent is taking less than 15 or 20 minutes, you're going way too fast. Way too fast. We all speak the jargon. We all know the OARs. We all know the rules and everything like that. But the person sitting in front of us has no clue. They have no idea. And with an adolescent, you really need to make it clear to them who the client is, that they're the client, not the parent. Make it clear to the parents, the kid is my client. I put that at the bottom. Remind the parents that experimentation is normal, and help parents find their own support network outside of you. I definitely had lots of dads that eventually would come to treatment more with me in the name of bringing their kids, and their wives were like, what'd you do to him? And I'm like, what are you talking about? He's like, well, I've been trying to get him to go see a therapist forever, but he'll talk to you. And I was like, yeah, I'm glad, but that's probably not good. That means he's needing some support that he's not getting. You are the therapist of the kid, of the teenager, right? Informed consent, what are the limits of confidentiality? What does it mean? Respecting it. Before I talk to your parents today about our session, is there anything you don't want me to say to them? I know a lot of people who are afraid to ask that question, because what they don't want to do is go, well, you know what? Okay, that stuff we can leave out, but that I have to tell them. So how do you want to handle that conversation? And if you have good rapport, you'll work through it. But you got to do an in-depth informed consent, and often remind them. You know, I've had to tell a number of 17-year-olds who are dating an 18 or a 19-year-old who's still in high school, like, hey, how about we just don't talk about the exact age of your partner? Because I'm going to have to make a report. The person's 17, their boyfriend's 18. Technically, that's illegal, right? There's stuff like that. But if they tell me the guy's like 24 or the woman's like 25 or something, I'm like, yeah, we're talking about that. We're going to make a call. But you got to be honest about it. Be genuine, be authentic. Don't try to be cool. Just be yourself. Have a sense of humor. Have a sense of humor. Always be willing to laugh. Don't scold. Don't overcorrect. And you just got to laugh. You just got to laugh it out sometimes. That really works. Be willing to talk about the things that don't seem important to you. I don't know who here is a video gamer, but I am not. And I never have been, and I knew more about Call of Duty and Xbox and World of Warcraft than I ever in my life thought I would ever know. Because when I was trying to build rapport and engage with the kiddo, especially at an assessment, what are you into? What's your thing? Are you an Xbox, or are you a PS3 or whatever, PS4? Oh, are you a skate? What's your thing? Who's your team? Who's your this? Who's your that? What do you like about them? How do you be willing to talk about the stuff that doesn't seem important to you because it's important to them? It's identity formation. They're finding their identity through the things that they like and that they enjoy. And if you don't talk about those, you're not honoring their specific individual identity and what they find important. And so everything else won't matter. They won't believe that you are there for them. Questions, comments? Yes.
I appreciate you buying like Taco Bell and pizza snacks, because I think a lot of us are like pressured to get like balanced snacks and healthy choices, which is great or whatever. But like when it comes to meeting what kids want to eat, to bring them to the door, I appreciate your guidance and approval for pizza and Taco Bell.
We arrived at those decisions collectively as a group. For the group sessions, we arrived at those collectively as a group. Hey man, what do you guys want next week? We got to meet again next Monday. What do you guys want? oh, can we get Popeyes? It's kind of expensive. For graduation or something like that, we would get spendy with it. But yeah, like if I was like, well, we're gonna have apples. Yeah. 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 Anyone else? Questions, comments? All right. Thank you.